So when we looked into, when we're always focusing on what these new and improved therapies are coming forward with myelofibrosis, and certainly that's where the field's heading. But in reality, we're often challenged by patients that are dealing with significant anemia that have myelofibrosis, and this is really an area of unmet need, and we don't have great agents out there to help with that. And certainly there are some in development, but oftentimes now, if patients aren't really appropriate for JAK inhibitor therapy and they're transfusion dependent or have significant symptomatic anemia, we're focusing on our efforts on that aspect of the disease, often using ESAs, which are particularly helpful maybe early on in the disease process in patients that have low serum EPO levels. We're also looking at androgens and then this group of immunomodulatory IMiD agents such as lenalidomide and thalidomide. We've used these agents pretty significantly at our institution, so we thought it best to look back and try to compare and contrast our successes and maybe our experience with using these agents. And what we found is first off, there's just a different patient population we're using for each. Oftentimes we're reaching for thalidomide in patients that are anemic and thrombocytopenic, and we're reaching for lenalidomide in patients that have preserved platelet counts but are still anemic. And that thrombocytopenic patient population is certainly a more high-risk patient population. We know thrombocytopenia is a risk factor for progression of disease and survival. In the same way, lenalidomide seemed to be used in maybe a less acute scenario in patients that didn't have as many mutations, that didn't have thrombocytopenia. And so really that did play out. What we saw is that patients who achieved responses with lenalidomide actually achieved a survival benefit that went along with that. On the other hand, patients who were treated with thalidomide who responded didn't really have a survival benefit that went along with that response. And at first that was a curious finding to us, because if you were able to improve anemia with similar rates between thalidomide and lenalidomide, why is one group achieving a survival benefit and the other not? And what it comes down to is that those thalidomide treated patients are a different group of patients. They're often more thrombocytopenic. They have high-risk splicing mutations. And ultimately, even though you can help with the anemia, really the underlying genetics of the disease typically drive the disease. And so ultimately survival is not too impacted by the anemia improvement. And so certainly this is a single center study with caveats galore and bears looking into it larger groups of patients. But once again, I think the take-home points here are lenalidomide and thalidomide are effective agents in improving anemia and providing anemia benefits. They're not going to change the underlying genetics of the disease, and in patients with high-risk mutations, that's going to drive the disease regardless. But these are agents we can use if we want to kind of aim to improve hemoglobin status, and specifically with thalidomide, it's an agent we can use in patients that are anemic and thrombocytopenic because it does appear safe in that group of patients.